Okay, I'd like to talk to you about a study that we did for people with heroin addiction a few years ago called the NAOMI study. And it looked at the question of what to do for people with heroin addiction for whom the current treatment, methadone, was not providing benefit. So our goal was to compare the effectiveness of medically prescribed diacetylmorphine, or DAM, which is the active ingredient in heroin, and we wanted to compare it with oral methadone, which is the best treatment currently available. And this was for the treatment of people who had not benefited from conventional therapies in the past and remained outside of the addiction treatment system. So this is the look at what the study design is. We would assemble a total sample of people, and they would randomize into one of three groups. On the left-hand side, you see that 45% would receive methadone, which is an oral drug you take once a day. The middle group, 45%, would receive injectable diacetylmorphine or injectable heroin. And over on the right, you see a small group of 10% would receive hydromorphone, which is a drug very similar to heroin, but it's legal and licensed. And the purpose of this group was so that we could look for heroin metabolites in the urine to test whether the people were where their responses were valid with respect to self-reported drug use. The DAM and the hydromorphone were done on a double-blind basis, meaning we, the investigators and doctors, didn't know which drug it was, and the participants did not know which drug it was. You can also see on the left side that the main treatment comparison will be between the two left-hand groups. These are the criteria to get into the study. You had to meet the definition of opioid dependence according to the Diagnostic and Statistical Manual. 25 years of age or older, 5 years or more of opioid dependence, regular predominant use of heroin in the prior year, at least 2 prior treatment attempts, including 1 of methadone at least, and you had to have no treatment for heroin addiction in the prior 6 months. These are the long definitions, which I won't go through, but we defined 2 things we wanted to happen. We wanted people to be retained in treatment, and we wanted people to exhibit a positive clinical response. It's very important in these kinds of clinical trials that you define the outcomes in advance of the study and not during it, after which the data has started to be collected. This is just a quick look of the profile of participants. You can see about 35 to 40 years of age. Incidentally, I may not have mentioned, but the trial was done in Vancouver and Montreal, although a larger number of participants were recruited in Vancouver. About just under 40% were female in Vancouver, 31% were Aboriginal, none in Montreal. Vast majority of people in Vancouver had precarious housing in the downtown east side, high degrees of unemployment, high degrees of welfare assistance and illegal income. About 19% involved in sex work in Vancouver. Most people had been charged for a crime in the past, and more than half had been convicted, 87% in Vancouver. Many days of illegal activity in the prior month, particularly in Vancouver, and spending about $1,200 to $1,500 a month on purchasing drugs. The profile of the participants in terms of drug use, you can see by definition they were using heroin most days of the month. Crack cocaine used more in Vancouver, about 17 days per month. And in the bottom of the table, you can see that they had been injecting drugs from an average of 13 to 17 years in the past, meaning that these were very street-entrenched, hardcore heroin addicted people. So here's how the trial looked after the flow diagram, which we have for all clinical trials. This shows what happened to all of the participants. We initially assessed 581 people for eligibility, but 330 were excluded. most of whom did not meet the inclusion criteria, and another 100 or so who dropped out during screening. That left us with 251 volunteers who were randomized to the three groups: 111 in oral methadone, 115 in diacetylmorphine, and 25 to hydromorphone. And then the boxes tell you what happened to each of the people, so it's a complete accounting of everyone who entered the trial. And on the left side, you see in the bottom boxes the number of people who are available for different types of analyses. In terms of other characteristics, vast majority hepatitis C positive, 66% in Vancouver, just under 10% HIV positivity, high degrees of suicide in the past, a median of 3 methadone attempts in the past in both groups, and a total of 7 treatment attempts of any kind, and they had all had an average of 3.5 to 6 non-fatal overdoses previously. And this slide presents the main results. On the left-hand side, the blue bar is the methadone group. 54% were retained, whereas the black bar, the heroin group, almost 90% were retained. On the right side, which is the clinical response, 2/3 of the diacetylmorphine group, 67%, attained a positive clinical response, compared to only about 48% of the methadone group. And if you look at the bottom, you can see, for those of you who understand tests of hypotheses and significance, that these differences were highly significant, p less than 0.001 and p equals 0.004 for response, so highly statistically significant findings. And these are graphical representations of what happened over time. This is the number of days of street heroin use. It fell in the oral group, the methadone group, substantially, because quite a few people were retained on methadone, and for them it worked. But you can see how much better the diacetylmorphine group, the black group, did, falling to just about 5 days per month from 25. This is the use of cocaine over the month, and the most important thing about this slide is that there was no increase, because critics would sometimes argue that if we simply provide people with free heroin, they will divert their money into buying higher levels of other drugs, and we did not see that in this analysis. This is a look at the money spent on drugs, more profound again in the diacetylmorphine group. This is days of illegal activity. They end up being roughly equivalent. And then we look at an important thing in clinical trials are adverse events, which are side effects that occur in the different groups that we think are related to the treatments. So we had 109,000 odd treatment injections in the study, and as we expected, we saw a fair number of cases of drowsiness, as you'd expect, and local histamine reactions, itchiness and pins and needles in the arm in which the injection occurred. Yet out of 109,000 injections, there were only 7 episodes of seizure, mostly in people who had a previous history of epilepsy. And there were only 13 episodes of oversedation where we had to treat the person with oxygen and a drug called Narcan, which reverses the effects of heroin. So 13 out of 109,000, no hospitalizations occurred as a result of this. They were all treated at the clinic and left. And so this is a far, far lower rate than you would see in 109,000 injections that occur in alleys and in hotel rooms and so on using street heroin. The oversedations were often associated with ongoing use of benzodiazepines, which is the class of drugs that includes Valium and other drugs for anxiety. So we concluded as a result of this trial that heroin-assisted therapy is safe, highly effective in terms of retention, decreasing street use, decreasing criminal activity, decreasing spending on drugs, and improving physical and psychological health. We noted a high retention and response rate in this very difficult to treat population, and we concluded that heroin-assisted therapy and optimized methadone both have important roles to play. We would argue that methadone should remain the drug of first choice, and it will be beneficial for a large number of people, but for those for whom repeated attempts of methadone have not been successful, we believe that heroin-assisted therapy should be offered, and unfortunately, at this time in Canada, that is not the case. And we were very fortunate to be able to publish this trial in the New England Journal of Medicine, which greatly helped us because of the credibility of the journal in addressing critics who wanted to find fault with our study. Thank you.